Hello, and thank you for joining part one of our webinar series, Abdominal Pain, Anxiety, and How to Help Your Teen During COVID-19. I'm Georgia Weston, and I'm the Executive Director of CHYP, Creative Healing for Youth in Pain. We are a nonprofit providing educational resources like this webinar series, exposure to creative healing experiences, and social support online. And CHYP is about more than looking just at the pain itself, but really broadening our understanding of health and wellness to include all kinds of overlapping issues. Physical and emotional pain tends to lead to a snowball effect of sorts. So CHYP also helps families dealing with anxiety, depression, stress, and so many more diagnoses due to messages stuck in similar sticky neural loops that we'll be talking about. And we know the tools teens can use to unstick that loop and help change the messages going to and from their brains. So thank you all for joining us today. We have a great discussion lined up with your live Q&A questions. We would like to ask that everyone please keep themselves muted and your cameras off so we can all enjoy without distractions, but you are able to type your questions into the Zoom chat throughout the discussion for our speakers to address. The Zoom chat you can find at the bottom of your screen. And now I am pleased to introduce CHYP's board member, Dana Pacholski, who will be moderating our conversation for our guest today, Dr. David Ziring. Dana also serves on the board of the UCLA Resnick Neuropsychiatric Hospital, is co-chair of the Regenerative Medicine Institute campaign for Cedars-Sinai, the vice chair of Cedars-Sinai's Innovation Center project for the Board of Governors, and is a board member for the Caton Children's Museum. Now I will hand it over to Dana to introduce Dr. Ziring and lead our discussion. Thank you, Dana.
Thank you, Georgia. Good morning, everybody. It is my honor to be able to introduce Dr. Ziring today. Dr. Ziring is an associate director of the Cedars-Sinai Pediatric Inflammatory Bowel Disease Program and an associate professor of clinical pediatrics at David Geffen School of Medicine at UCLA. We are so grateful to have him here this morning and sharing his wisdom with our community. Good morning, Dr. Ziring.
Good morning. Good morning, Dana. Good morning, Georgia and Lonnie. And I do see a bunch of friends in the audience, so it's nice to connect with you all. So I was asked today to speak about how our children or adolescents are handling the pandemic, and especially when it comes to pronounced GI symptoms that have really reared their ugly heads over the last year of the pandemic. So it's interesting. I mean, there are a group of patients that I care for who are very introverted and very shy, and perhaps some patients who may be a little socially awkward, who are actually doing quite well during the pandemic. And they've actually been thriving, and their symptoms are minimal. And I fear the time that they have to go back to in-person learning because they've been doing so beautifully. But on the other hand, there is an epidemic going along with the pandemic of children who've been suffering from having to be safer at home to be safe from the viral infection. And especially here in California, where the public school systems have been shut down for the last year, and our children find themselves remote learning, we've seen an uptick in the number of patients who present with abdominal pain and nausea and weight loss and vomiting, bloating and gas and other kinds of GI symptoms. And so I'd like to talk to you today about, how do we recognize these things? How do we best address them? And in terms of my practice, I come from a point of wellness, of maintaining wellness, rather than a perspective on treating disease. Because I think that we make a bigger impact on individuals, on children and their families and society from a wellness perspective. So we'll be talking about that. I realize that every child is an individual, and every child may process their environment differently. And every child has advantages and disadvantages coming into the pandemic in terms of whether their parents are working, whether they have stay-at-home parents, whether they have all the resources needed to attend school and thrive, or whether our disadvantaged patients have parents on the front lines and are being tended for by their grandparents and maybe don't have internet access and have really been struggling in terms of resources. So there are all kinds of reasons why our patients have had struggles this past year. And I'm looking forward to having a conversation with you about what we can do to address these concerns.
Dr. Ziring, one of the broadest questions I can ask, and I know you're going to cover this, but I want to set the stage for it, is how the gut and our stomach sends messages to alert us that there's something else going on, and how and when to know what to do. So for example, maybe if you could start from the child who's at home who just has stomachache after eating or perceived stomachache after eating, but it may be something else. So I'd love to start there and then work out, if you don't mind.
Sure. So, I mean, that question gets at when do I need to worry about my child, right? So, as a pediatric gastroenterologist, I try and take a very thorough history so that I can get at what are some red flags that would prompt a workup. Irritable bowel syndrome, which is a description of symptoms of abdominal pain and a change in bowel habits that have occurred over the last several months. That is a functional disorder, but it used to be defined as a set of symptoms having had an entire workup and the entire workup being negative. So, having blood tests and stool tests and endoscopies and imaging, and then being declared as having IBS. But that definition has changed over the last few years so that now IBS is a positive diagnosis. So if you have these symptoms, you have IBS and we don't necessarily need to do any testing at all, right? There are a number of signs and symptoms that cause us concern to the point that we consider doing some focused, limited testing. And those concerns are brought up by what we call red flags or warning signs. And those red flags may be weight loss, unexplained fevers, a particular type of abdominal pain. So the most frequent reason why we see abdominal pain in children is that it is centers around the belly button. And if the pain is remote from the belly button, if it's in one corner of the abdomen in particular, then that may cause us some concern as well. If patients have blood in their stools or chronic diarrhea, if they have weight loss, if they are waking up at night, although it's not always a worrying sign, it still prompts us to look a little bit deeper and find out, could something else be going on? So those are all reasons why you might want to reach out to your pediatrician and get a referral to a subspecialist like me to be evaluated.
That's really helpful. And with the kids that, let's just say they have this IBS diagnosis, and I'm linking this back to the anxiety portion for a moment, and we can dive back into the more physical side of this. What is your recommendation? Because I know how close you work with CHYP and with Dr. Zeltzer. I'd love to talk about the anxiety gut response and the body's warning signals to us, especially. Yeah.
So I think it's important to understand the underlying processes that cause abdominal pain in the setting of anxiety, right? So, the frequent presentation to me is a child, often a teenager, who is very high functioning, very bright, but with those qualities, with those advantages, come some disadvantages because their brains are tuned to certain frequencies, right? They are very bright, but they are also very aware of their surroundings, and they have these little parts in their brains that are responsible for vigilance, meaning they scan the environment for threats. And that probably helped us when we were cavemen in running away from from bears and the like. But these days, these very bright kids who are straight A students and on the honor roll and chess club and debate club and in the orchestra and doing 16 extracurriculars, they also tend to have these hyper developed vigilance centers in the brain that scan the environment for threats constantly. So not only the external environment in making sure that their relationships with their peers and their parents and their siblings are appropriate, but the internal environment as well. And so when their brains scan the internal environment for threats, it picks up the tiniest little signals of, gurgling in the belly. Patients frequently say, I have a very rumbly tummy. That gurgling to you or me is easily dismissed. We just had a cup of coffee and so we've got a gurgly tummy. But in a child who has an overdeveloped vigilance center, and that gets back to an underlying, sometimes tendency towards becoming a bit anxious, they scan their internal environment for things like rumbly tummies, and it causes some worry and then pain, and then it amplifies. So it starts off oftentimes after dinner when a patient is getting ready for bed, lying in bed, reviewing the day's events, thinking about what they have to worry about tomorrow, and all of a sudden they feel a little twinge of something in their belly, and they say to themselves, I wonder what that was. That seems a little odd, and gosh, that's awfully uncomfortable. I don't think that's normal. In fact, I know that's not normal, and it's getting a lot worse. Oh my gosh, I better go tell my parents. I need to get out of bed, and I realize it's 2 a.m, but I need to wake them up and let them know that I'm really having a lot of pain here, and I think I might need to go to the hospital because now I need some blood tests and an ultrasound and even a CAT scan because I am in horrible pain. And so that's how these vigilance centers take small rumbly tummies and turn them into crises. And those sensations, the brain-gut connection and the communication between them is colored, is influenced, is shaded by what's going on outside of you and what's going on inside of you. And so when your brain is prone to getting anxious at times, then it tends to pick up on these hypervigilance signals. And I can see these patients in clinic, and it's very funny. Parents will tell me, no, my child's not anxious. And the kid will tell me, no, I'm not, I'm very laid back. But meanwhile, they're fumbling with their fingers, they're picking at their nails, they're bouncing their knees, they're fidgeting, and their heart is racing when I'm listening to their chest. They've got a heart rate of 110. And I say to myself, you may not feel like you're anxious, but you sure seem anxious. And so that's how anxiety impacts to a large degree on feelings of abdominal pain.
And it's incredible that you take note of the whole package in a world of doctors being so highly specialized. It's such a gift to have somebody like you who looks at exactly what's going on, environment, existing mannerisms, and everything else. And with those children, which I think is a huge amount of kids right now, what do we do? Because I know that when a child leaves and thinks, well, there's nothing wrong with me, but I'm living with this, then the mind starts to race and the vigilance centers start to really activate, and the gut brain connection starts to create these sticky neural loops that we talk about all the time. What would be your list of recommendations to help us as parents start to help our children either be aware or less aware in this case, right?
Yeah.
So untangle that web.
Yeah, I appreciate the compliments. I think that in addition to being observant, some of the questions that I ask when I take a history are things like, what time do you go to bed? What do you like to do? What do you think about when you're lying in bed? What time do you wake up in the morning? What do you have for breakfast, lunch, and dinner? How would you describe your mood? I talk to parents and I say, well, how would you describe your child? And so I really try and get as best an understanding of the child at that first visit as I can. so that I can almost get inside their brains and figure out what's driving them. And so when I spoke about wellness earlier, I really, take that as my philosophy. And so wellness extends to not only, meditation and stuff like that, but what time is the child getting to sleep? And what are they doing before they go to sleep? Are they on social media? Are they amped up by their friends who are posting glamour shots or gossiping about the odd girl out, or thinking about a boy who just mentioned something earlier about their shoes or something. And so I asked, when was the last time they looked at their social media? Where do they charge their phone? What time are they going to sleep? How late are they doing homework? So sleep is incredibly important in terms of wellness, and I drive that message home. Getting at least 8 hours of sleep for an older teenager, and more like 10 or 12 for a preteen is very important, because there are other centers in the brain that monitor what time of day it is and signal to your body that it's day or night. And those signals are very important in maintaining health. And if you're not sleeping adequately or have disordered sleep or poor sleep hygiene, then it really contributes to disease, to illness. And so one of the easiest things to do, one of the first things to do, is to work on sleep hygiene. So I do that. I talk about diet. We look at how diet contributes to pain. We look at eating patterns and relationships to food, anxiety surrounding food and eating. We talk about bathroom habits. We talk about all kinds of lifestyle issues. And then in terms of intervention, besides sleep hygiene, we talk about mindfulness, right? And so mindfulness is not a one-size-fits-all solution for our patients. When I discuss mindfulness with my patients, I bring up a whole bunch of ideas and I see what kind of gels with them. Because there are a lot of, teenage soccer star boys who are totally not into Pilates or meditation. They may look at yoga or acupuncture or hypnotherapy or biofeedback, but I really have to get a good feel for what's going to work with that patient. Because if I make a suggestion and I send them home, and it has very little chance of being appealing to the patient, then the next time I see them, they're not going to be any different. There's not going to be any improvement from visit to visit. And I'd rather not just check in with my patients to see them doing the same each time. I want to make some progress and make sure that they're feeling better. And a lot of that is making an alliance, not only with the parents, but with the child as well. And so, maintaining wellness with all of these interventions really is an individualized process and has to be targeted towards the interests of the patient.
With the kids that are now having anxiety around food, right? So they're now withholding and not eating maybe breakfast and lunch. And then eventually they kind of cave it and say, okay, I'll eat dinner. And then they go into this cycle of, now I have pain, see it's food. And they're confusing the signals as being from food. Can we talk a little bit about what you see with that and how?
Yeah. So I have so many patients who are going to sleep at 1 and 2 in the morning. And because of these crazy Zoom classes, they can sleep in until 10, and they skip breakfast. They're not very hungry for lunch. They may have some chips around 3 in the afternoon, and then they have Postmates for dinner, and then their parents get home late. And that's a crazy cycle. And then finally, their parents are taking good notes about, taking a diet history. And my child recognizes that every time he eats rice, or every time he eats chicken, or every time he eats potatoes, or every time he eats, kale, he gets belly pain. And if you look over these lists of foods, they don't make any sense. They don't follow any particular theme. All they are is food. And so then we recognize that it's not the particular kind of food that our patients are eating. And it doesn't make sense to necessarily go gluten-free, low FODMAP, vegan, soy-free, eating basically a diet of kale, when the issue is not the particular food that you're eating, but the fact that you're eating food and there's a big reflex that happens when you eat. So when you eat and your stomach distends with fluid or solids, that distension, that stretching of the stomach causes nerves to fire and sends impulses down to your colon to start contracting. And as your colon contracts, maybe you're a little constipated and it's trying to push along stuff, that gastrocolic reflex will cause pain, especially when you're prone to pain. So putting something in your stomach, having it fire and send impulses to your colon to contract, all of a sudden, 15 minutes into dinner, you push away from the dinner table and you run to the bathroom feeling like you better go or else you're going to be in horrible pain. And that's something that I see all the time. So it's not necessarily the particular food often that's the problem. Parents come to me with having spent thousands of dollars on food sensitivity testing, sent off to Rocky Mountain Spotted Labs or whatever it's called, and they've gone to naturopaths and holistic providers, and they've looked over their diet and they've said your diet is too high in yeast and too low in fermentable foods and too this or too that, and so you need to eat only rutabagas. There's a problem there. And so it's better to come see me first before doing a huge workup and finding a bunch of kind of nonsense results that don't help your child, so that we can talk about what really are contributing, what are these factors that are contributing to pain before we restrict your diet down to nothing. There are particular diets that can be helpful. So for patients who have recognizable bloating and gas and pain, often that follows a history of infection or frequent antibiotics. And I suspect a diagnosis of a condition called small intestinal bacterial overgrowth, or SIBO, S-I-B-O. I'll do testing for it. And if it's present, we'll do some treatment. We'll start a very limited diet called a low FODMAP diet, and only limited in time, right? Because a low FODMAP diet, while it can be therapeutic in patients with SIBO, is never meant to be a long-term diet. It's meant to be a 2 or 3 week diet as we assess and figure out what are the triggers that contribute to bloating, gas, and pain. And so we work through a special diet like that in a very scientific and measured way to figure out, okay, our patient can tolerate gluten and dairy, but can't tolerate onions and garlic. So we can make those assessments using a low FODMAP diet, but we have to work very closely together. And it's not a very good idea to go rogue and do these things on your own at the expense of missing out on valuable nutrients in the diet after months and months of a low FODMAP diet and not making really much progress at all.
It's really an epidemic right now of the SIBO. Everybody's going SIBO and saying, well, just do this low FODMAP. So it's really important you covered that. And I think in going back to what you said about basically this hypervigilance signaling and how the body has this smart brain pain syndrome and this relationship with the gut, these kids don't know what to do when that pain signal starts. So the one thing they are doing is saying, I'm just not going to eat food and I'll avoid it. But what is that? I'd love for you to discuss what that really does do for the body and how it probably doesn't help that signaling process.
No, restricting food leads to weight loss, leads to greater GI symptoms driven by weight loss itself. So what we recognize is in our children who lose significant amounts of weight, all of a sudden their motility suffers. Their stomach stops emptying very well. Their colon stops contracting. They get very constipated. They get nauseated. They lose their appetite. Their small bowel doesn't contract very well. Bacteria tend to ferment and grow and multiply. They do get SIBO. And so there are a lot of consequences to restricting food and losing weight on the GI system that only amplify the problems. And you get this snowball effect that we then have to kind of rebuild and start from scratch and work very slowly on a very long kind of rehabilitation. So, so recognizing that the problem is an intrinsic problem related to brain-gut communication and not necessarily related to eating is important. And let's figure out how we can manage eating without pain, because it may be that smaller, more frequent meals work better, or a different diet works better. But we can't avoid food altogether, because that causes big problems.
And also, what about the kids that, because they are not eating as regularly, are they actually gaining weight by altering this feeding schedule by, okay, I won't eat today, and then their body says, you're really hungry, eat extra now. So what is that doing to the gut?
Yeah, so there's all kinds of interesting research on how the body conserves energy, right? And so in moments of starvation, how the liver accumulates fat and how insulin is secreted and how metabolism works. So it doesn't necessarily help to starve yourself and then gorge yourself, because that does lead to problems with weight and weight gain and even fatty liver disease. And so no, adults have tried all kinds of crazy diets like intermittent fasting that seem to have benefits in adults who are trying to lose weight, but that's very different than an adolescent who suffers from chronic pain and is avoiding food because they feel that every time they eat, they get pain. Then there are other ways of dealing with pain. There's distraction, there's homeopathics, there is biofeedback and hypnotherapy and any number of a dozen different ways of treating pain that don't include restricting food intake.
I think that's really an important note for everybody listening right now, to really pay attention to the options you have and to get a structure, like you said, of what the body does and how I think a lot of kids right now have chosen not to eat for 2 meals, 3 meals, and then are finding this cycle to be exaggerated, and you just described why. So I think it's really important information for parents. One of the questions that's coming up is, would the internal pain signal cause a child to double over in pain?
For sure. There's a pain syndrome called abdominal migraine, where that's characteristic of abdominal migraine, where children actually do double up. They turn pale, they get sweaty, they double up in pain, and it can be mistaken for something serious like appendicitis. And so that's not unusual. And while it may be a bit scary to witness, especially if it's your own child, oftentimes the reasoning behind it is rather innocent, and it's not something that requires an ER visit, a CAT scan, a blood test, and a trip to the operating room. So yes, it's not unusual for patients who have these what we call functional pain disorders to double over in pain and curl up and want to spend the day in bed.
And what about the kids who started out with stomach pain, general stomach pain, and then they know it's emotional, and now they've started to vomit?
Mm-hmm.
There's no other real obvious symptoms.
I've seen that during the pandemic. I've seen a pandemic of vomiting as well, especially amongst teens. Again, oftentimes exacerbated by periods of anxiety and panic attack, where patients will admit to me that, it really did feel like my heart was racing. I was starting to get chest pain I ran to the bathroom, I felt horribly nauseated, and I threw up. And so that sequence of events is called functional dyspepsia, that feeling of upper abdominal discomfort and nausea and vomiting. And it's something that I do see frequently, and sometimes it's even associated with weight loss. And again, it's important that, that a specialist kind of recognizes that and takes care of it. We do consider the possibility that there are other things at play in terms of vomiting and pain, things like H. pylori infection causing ulcers or things like that. I even have patients, because of their anxiety and being stuck at home and far from their friends, they're vaping marijuana, and they're getting cannabinoid hyperemesis syndrome. So these patients get pain, they get recurrent vomiting, they get weight loss. They haven't been telling their parents that they've been vaping, but they've been vaping marijuana. And sometimes they even feel like taking a hot shower makes them feel better. And we recognize that as a relatively newly diagnosed syndrome, but something that seems to be more prevalent these days with our patients who are stuck at home and have no outlet for their anxiety and feel like they can't connect with their peers. Sometimes they've been vaping and taking the edge off by smoking marijuana. So I've seen that as well.
Do you think that's more relevant to smoking marijuana versus the gummies or other edibles that have low THC?
I don't know that it matters necessarily. I think that any way that you get cannabinoids in your system, you're at risk of cannabinoid hyperemesis syndrome. So it's something to be aware of. You don't have to be crazy obsessed that your child is smoking pot behind your back, but it's a consideration that I keep in mind. And after a video visit, I've often asked parents to leave the room so I can have a quick chat with a teenager and say, how much pot do you smoke? Because oftentimes they'll tell me that they've been doing it for a year, and they feel like they really need it. And they need it for their nerves, to settle them down, to get sleep. And yes, they are vomiting and have pain and weight loss. So it's something that I've been recognizing.
That's a really interesting twist on that.
Yeah.
Going back to the migraine treatments for abdominal migraines, are there any treatments that you've come across that you've found useful?
There are all kinds of treatments for abdominal migraines. And so many of them are prescription treatments, ranging from old antihistamines like Periactin, to beta blockers that are used for patients who have stage fright, to tricyclic antidepressants that are used for patients who have chronic pain. And then, we employ some degree of herbal therapy as well. There are herbal concoctions that seem to help with abdominal pain. That parents have found helpful, concoctions like Iberogast and things like that. So there are all kinds of ways that we employ to treat abdominal migraine, chronic abdominal pain, and I've found that groups like CHYP and Lonnie and Whole Child LA have been really very helpful in approaching it from many different angles, because I tell parents, you know what, just seeing me isn't going to solve your child's abdominal pain. We're going to have to bring in all kinds of friends to help manage these things. If you can attack it from a dozen different angles, besides a pediatric GI perspective, you're going to have the most luck in treating your child's pain. So if you see me, and then you go and see a therapist, and possibly a psychiatrist, and somebody who does biofeedback, an acupuncturist, somebody who does yoga or Pilates, somebody who can teach you mindfulness. We use mindfulness apps for those patients who prefer to be on their phones. If you can attack this from a dozen different angles, you're more likely to have significant resolution of your chronic abdominal pain.
Well, it sounds like exactly what CHYP is well poised to do, which is help the whole body start to change the signaling. But we start with awareness, because most people don't know a lot of the things that you've shared with us today, which have been incredible, because you start with the stomach and we again get hyper focused on the stomach. But the stomach it can be an effect, not the cause.
Well, and there are different practices, right? So my practice style is very different than some other pediatric GIs around Los Angeles. Some pediatric GIs in private practice don't have the time necessarily to spend with their patients the way that we do here at Cedars, taking a very careful history and getting to know your child. And so it really takes some education, and sometimes that can't be done completely during the first visit. It takes a follow-up phone call or video visit or follow-up visit, but we do a lot of education. And then we try and minimize the amount of testing we do, because a lot of testing provides zero benefit. There was an interesting study that looked at whether doing an upper endoscopy or an upper endoscopy and colonoscopy helped reassure parents that their child's abdominal pain was an innocent source of pain. And what they found out was that no, it didn't help at all. All it did was increase costs, subject children to invasive procedures under anesthesia at the expense of giving up a school day and anxiety and all the rest that comes with those procedures. And it didn't help parents or patients feel any better about their abdominal pain. So there should be a limit placed on a workup. It shouldn't be $1 million workup every single time. Parents should understand that if a physician is very confident that their child's abdominal pain has an innocent source, that we leave it at that, because even continuing to do more and more and more and more tests only validates the idea that their pain is something to be concerned about, right? And so if I'm ordering a CAT scan and a colonoscopy and a biopsy and 16 other tests, the more and more tests I do with normal results, the more parents and their children buy into the idea that this doctor really is very concerned about my child having pain and looking for an underlying diagnosis. He hasn't been able to find one yet, but maybe if he does another dozen tests, he'll figure it out. And then the child is left thinking, gosh, something is really seriously wrong with me. And that doesn't get us any closer to getting your child feeling better. If the goal is getting the child feeling better, then subjecting them to 100 different tests is not the solution.
Well, and it could further complicate any autonomic dysfunction that's already experiencing. And then we just went through this with somebody I know who decided to run, the massive testing. And I cautioned them and said, you have to do that as a parent. I understand you feel that you need to turn over every stone. However, concurrently, maybe look into autonomic function, understand how the body's processing this, because you're going to most likely leave this massive testing process that your child was hopeful for a diagnosis. I mean, they get to the stage where they are praying for a diagnosis, which clearly is not in anybody's best interest.
Yeah.
Except for
and the diagnosis of chronic abdominal pain is a legitimate diagnosis, and a parent should be just as satisfied with the diagnosis of chronic abdominal pain as they would be with the diagnosis of some other chronic illness that they certainly don't want their child to have, right? So I'm a specialist in taking care of kids who have Crohn's disease and ulcerative colitis. You don't want your child to have those things. You want your child to be healthy. And when I tell you that your child is healthy but has pain, let's leave it at that. Feel grateful. Let's treat the pain. And let's not look for Crohn's disease if it's not there, because you don't want that diagnosis. I'm sure that all of the parents that I care for would wish 1,000,000 times over that their child had chronic abdominal pain and not Crohn's disease. And so be grateful for that diagnosis, and let's accept it and treat it appropriately and get better and get healthy.
So one of the questions is, how can you help your child distinguish between anxiety-related stomach pain and other causes of stomach pain, especially if your child doesn't identify as someone with anxiety?
So I think it's important that you have an objective observer who doesn't spend 24/7 with your child figure out what it is that's contributing to abdominal pain. To take a very careful history, as I've described, to get to know your child well, and make that assessment for him or herself, right? So, you know, if I take a careful history and I'm worried that the child may be at risk of having something like celiac disease, I'll certainly screen for those kinds of things. And we'll make sure that the most common diagnoses that contribute to chronic abdominal pain are not present. But that's a focused, limited set of tests, without having to go into doing colonoscopies and CAT scans and all the rest. So leave it to the experts to kind of figure that out, and place your faith in them. Before you question the capabilities of the physician that you're seeing, and turn to online forums and Google and Wellness Today and blah 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 blah.com, where somebody is touting the latest in ozone therapy. Just put some faith in the medical system and physicians who have the experience and are trained to look for these things, because we can be your best allies.
We need a lot more Dr. David Zierings out there. That's what I say. A whole body approach. What you just touched upon celiac screening. Could you talk a little bit about that? What would cause you to recommend somebody for that, and then what that really means?
Yeah, so celiac disease affects nearly 1% of the population, so it's very, you know, relatively prevalent. And so it's something that we don't want to miss, because it can cause problems down the road. And so I often take a family history and I say, you know, your last name is McCleary. McCleary sounds like Scottish or Irish or something. Is it possible that your family generations ago came from Northern Europe? You know, patients from Northern Europe may be at risk of having celiac disease because it's a genetically mediated disease disorder, and I think it's important that we screen for it. So I do take a very thorough history, and I look for heritage that would put patients at risk of celiac disease. And I'm more likely than not to screen for it in the setting of chronic abdominal pain, weight loss, change in bowel habits, headaches. I mean, celiac disease can present in all kinds of ways: brain fog, all kinds of signs and symptoms that can present suspicious for celiac disease.
And what is it? Just a simple lab test, blood test, or there?
Yeah, so there's a blood test where we order 3 different blood tests that measure various antibodies, and those antibody patterns are very sensitive and specific for finding celiac disease, on the order of 97%, right? So if we have done celiac disease screening and it's all negative, we can say with 97% confidence that your child is unlikely to have celiac disease.
That's, I mean, usually you don't get such a high number, which is amazing to be able to rule in or out, hopefully out. And what about, and this is just a little bit of a twist, but for kids that already have anxiety, already have this gut-brain anxiety, autonomic, patterning, smart brain pain syndrome, where the neurons are heightened, and they're afraid of blood tests, what do you do to recommend for those kids that clearly need some workup and are reluctant?
Yeah, so it's tough, and it's not only the patients, but it's their parents too. I saw a parent last week who was older and hadn't left the house since last March. And while I recommended some testing, she wanted to defer and didn't want to bring her child out into the community to their local Quest or down to Cedars to have blood drawn because of the pandemic itself. So that does happen. But a child with a significant anxiety and surrounding blood draws, again, perhaps it would be helpful to meet with a therapist first to do some visualization, some mindfulness exercises to learn what it is that they want to do as the blood draw is happening, what a blood draw is all about. I have had patients who require IV medications meet several times with a therapist up front to help visualize what that would be like, to distract using an iPad, to imagine kind of what that might entail, so that when it's time for a blood test, it's not as anxiety provoking as it might be.
But either way, a blood test is the only
When a physician recommends a blood test, they're often suspicious that something may be going on, and so they do it for a reason. And so I don't always recommend blood tests, but when I do, I do it because I'm making that recommendation, and I would hope that eventually parents would be able to get their child in for a blood test.
It takes a whole separate PhD, let me tell you. Going back a little bit on the, and I'm going to read this word, the functional dyspepsia. Is there a way to differentiate between functional dyspepsia and regurgitation?
Yeah, so functional dyspepsia is similar to irritable bowel syndrome in that it's a list of signs and symptoms that a patient has that fulfills a diagnosis. And so it's upper abdominal discomfort, it's nausea, sometimes it's vomiting, sometimes it's heartburn. A symptom of heartburn or sore throat associated with those things that's not necessarily gastroesophageal reflux. So there's that. And then there are other functional GI disorders related to regurgitating food. There's a condition called rumination syndrome, where patients subconsciously or unconsciously and effortlessly bring up stomach contents into their mouths and have to go over to the closest garbage can and spit it out. But it's not associated with a lot of retching or effort or that kind of thing. It's a subconscious but learned behavior, often in the setting of anxiety, and responds very well to things like diaphragmatic breathing, learning how to place your hands on your chest and abdomen and where your hands should be moving in conjunction with a therapist. It benefits from other kinds of modalities, but regurgitation or rumination syndrome and functional dyspepsia may have some overlaps, but they are their own entities. And again, a subspecialist can help you figure that out.
It's an interesting I think we're hearing so much about it right now. And I think you're seeing a lot of kids that are doing that, and then the fear that they're going to do it, and then they end up not wanting to go places.
Yeah.
Fear that's going to happen.
They're stuck at home, and it just worsens their anxiety, and they do it more, and their parents start to worry. And that positive feedback for that behavior causes that behavior to persist and worsen.
A parent just wrote something that I think is really important to discuss, because I think as parents, and as I'm a parent of 2 children that have had all kinds of fun times in the medical world, I've learned a lot about what I bring to the party. So as a parent, when we come meet and we're telling this story in front of you, and we're reiterating, my child has this and my child has that, I'd love to talk a little bit about, as parents, from your perspective as a specialist, what we can do to mitigate the conversation about this, but not, I want to acknowledge this is legitimate, that they're feeling something.
Oh yeah. That dynamic is something that I'm very attuned to. And it's all over the place. I've had parents email me before their first visit to say, please don't discuss this in front of my child, because it makes him or her very anxious. Please don't discuss food. Please don't discuss weight. Please don't discuss anxiety. Please don't discuss school. And so I'm trying to constantly remind myself during the visit, gosh, don't bring this up, don't bring that up. And I'm kind of navigating a minefield. So there's that extreme. There's the other extreme where parents and children are constantly bickering during the entire visit. That, Mom, I'm fine. No, on Sunday evening, you were retching and vomiting. Mom, I was not. That was last Thursday. Okay, well, it was last Thursday, but you were still retching and vomiting. And so there's a constant argument between parent and child. So there's that dynamic. Then there's the talking over the child, and the child is very timid and doesn't say a word the entire visit kind of dynamic, where, the parent has 72 pages of paper-clipped records, along with pictures of bowel movements, diet histories going back the last year, every single test result. Sometimes it's spiral bound, it's been bound by Kinko's, it's in presentation format, they've got it on an iPad in terms of a PowerPoint presentation. There's all kinds of ways that parents present information. Usually the best way to have a visit together is for a collaborative visit where a child can start off kind of describing what they're feeling. I can have a discussion with the child, and then I will turn to the parent and say, is there anything that the story is missing that you'd like to contribute? Why don't you tell me about what you are fearful of? What are some things that you're worried about? Because your child doesn't have cancer. Is that something that you're worried about? This weight loss and abdominal pain, it's not gastric cancer, it's not colon cancer, it's not pancreatic cancer. These are things that old people get, right? And your 12-year-old doesn't have these things. So we talk about what their fears are. And so there are all kinds of ways that we navigate the relationship in the clinic exam room during that first visit. But the best way is an open-ended, collaborative kind of conversation, sometimes leaving some time for the adolescents to be able to tell me stuff kind of off the record, stuff that they might not share with their parents, fears and anxieties that they may have that they're keeping from their parents, because that can be very important as well. So it makes for a very complicated visit, but it's like working at the UN or being a hostage negotiator. We have to figure out where to interject, when to ask the appropriate questions, when to bring in each party, so that we can have a good dialogue and get the information that I need so that patients can start feeling better.
And I think that nobody wants your children to be receiving attention by going to a doctor. And so we really do want to break these cycles. And, it's a really good question, right? What if you're already working with the psychologist and you've got your team really engaged? So you're not just working with one specialist, you've got a multimodality approach. How do you really recommend the parents assist in breaking the cycle that the child's not eating properly if you've already got a big approach to this and you're still struggling with the eating cycle?
Well, we talk about the relationship with food. I talk about everybody has a different relationship to eating, right? There are eat to live people, and then there are live to eat people. And I certainly have my share of patients who eat to live and snack on the bare minimum number of calories in order to maintain their weight, because they're very interested in making sure that their debate performance is up to par, or that they score the winning goal or whatever. So we talk about relationships to food. But overall, again, it's going to be a multi-modality kind of approach. And so there's a certain amount that I can do in clinic in kind of partnership with the patient and parents in terms of eating. But sometimes it requires extra time and attention and expertise. And it's groups like Whole Child LA and my CHYP that are really very helpful in dealing with those kinds of underlying issues. Because, I certainly don't have a degree in psychology. I have experience as a pediatric GI. And I certainly know the literature when it comes to functional abdominal pain and functional GI syndromes, and I can be empathic and tell you what I think is best. But sometimes it takes extra time and attention that other providers can more easily give.
Well, it was really great to start off with you, Dr. Ziring, because we really wanted to talk about the physical body and its relationship to all the other systems. On Friday, we'll be speaking with Dr. Samantha Levy at 10 a.m. doing the same thing, and we will cover many more topics about how we can help parents help their children through this from the psychological side. And then I get the opportunity to speak with Dr. Zeltzer directly next week and cover. So we're going to be a very well-rounded series, but having the information that you provided today has been so helpful. And I think the takeaways, if we could do a quick recap and give a takeaway about when again, if you could describe where the pain is, in a general term, obviously, to look for more testing, to be more concerned as a parent, not to go to the hospital, but to even seek help with somebody like you, on out to, you mentioned some other modality, not the modalities, but you mentioned some herbal remedies and things like that. If there's anything you feel comfortable sharing, I think that would be the greatest way to end, to wrap up our session today with some takeaways.
Sure. So studies would indicate that up to 40% of school-age children will experience abdominal pain on a recurrent basis, right? And so parents should recognize that they may be part of that 40%. If pain is centered around the belly button, if it's not associated with diarrhea, blood in the stools, unexplained fevers, joint pains, nighttime awakening, red flags, then it can often be managed through distraction, through homeopathics at home, without necessarily seeking out the expertise of a subspecialist. We're always here to help guide you through the management of abdominal pain, using those modalities, peppermint, ginger, other homeopathics, topical therapies. There are all kinds of ways that we can treat pain that don't involve taking a pill. And those are things that I really reach out for first, because I believe in them, and because pain gets better. And if we can avoid having to have patients and their parents buy into the illness model, where there's a bunch of testing done without results, only to spend time and energy on that. If we can adopt a wellness model, then it will ultimately benefit them in the long term. And really what I'm looking for is, how do we get your 10-year-old into middle school and high school, graduate, get out on their own, be a successful college student who's living on his or her own in the dorms and navigating relationships, graduating from college, getting their first job. So I have my view not only on this particular moment and this particular child at age 10, but what does life look like for them going forwards, and how can we set them up with the skills they need to manage on their own, without buying into an illness model, so that we establish this idea of wellness for the future, so that they can be successful children and make you proud.
I really appreciate it, Dr. Ziring. I had a couple extra questions that just popped up, and I know that we're at our time, but if you don't mind, I'm going to ask you, just because I love to honor that people come on because they know they have a live opportunity to ask their questions. So, and it's something we didn't cover. Constipation.
Yeah.
Chronic constipation. If you just give us a quickie on what your recommendations are in treatment.
Yeah. So constipation, the first change we make is diet. The next change we make is timing. The next change we make is positioning. And then beyond that, it's we talk about laxatives, and we talk about any testing that needs to be done. But in terms of diet, oftentimes it's the pitted fruits. It's making sure patients are getting enough fiber in their diet, that they're getting adequate fluid. With positioning, with timing, taking advantage of that gastrocolic reflex and sitting on the potty a half hour after meals when your colon is contracting, and working with that reflex to have the best chance of a positive outcome. Using a squatty potty and getting the knees up in the air, bending the pelvis into the right angle so that it helps with constipation. And then we talk about, well, now do we need to use some magnesium to help soften stools? Do we need some Miralax? Do we need some Senna? Are there other ways to help with constipation? And so these are things that I do several times a day here in clinic. Oftentimes pediatricians are relatively good about treating constipation. Sometimes they throw up their hands and they ask for our help, and we're always here to help out.
Well, again, Dr. Ziring, I know I tried to cover everybody's questions. There may be they had some very specific questions today, so I tried to integrate it. I apologize if I didn't make it. If you have a few minutes, I have a couple more. If not, I know how valuable your time is, and you probably have a group of patients waiting for you. So we want to make sure you get back to them if you need to run.
I can spend a couple of minutes. I'm supposed to call a mom in just a couple of minutes to talk about her son, but I'm happy to talk.
Just so I can cover a couple of these specific, with regards to constipation, fiber. What's your feeling about fiber?
Fiber should come from foods. Fiber should not come in a gummy or a pill or a powder or whatever else people have come up with to get fiber in your body. You should eat fiber in your diet because foods that contain fiber also contain important other nutrients like prebiotics that feed your gut and feed the microbiome and enrich it and make you healthier. And so for a patient who subsists on Cheerios and mac and cheese and grilled cheese and pizza and bagels and lox and cream cheese, so all of my constipated kids, if they could only ditch those foods and have oatmeal with blackberries and raspberries and flaxseed and Fiber One and Raisin Bran and all kinds of other stuff, if they ate that fiber rather than tried to get it through a quick fix exogenous kind of pill or gummy or powder, they'd be a lot healthier.
No, that's great. Thank you. And then back to the SIBO question real quick. To treat or not to treat? Do you take those scary pills? Do you let it go and see how you feel?
So it depends on what the contribution is to your symptoms. So SIBO often doesn't exist in a vacuum. SIBO often complicates the histories of people who have irritable bowel syndrome. So it's not often an exclusive diagnosis. It often comes on the tail of IBS. And if your SIBO is giving you symptoms, if it's giving you bloating, gas, abdominal pain, and diarrhea, or any combination of those things, and it makes you feel miserable, then treat it. Certainly the pills work a lot faster than diet. Diet can take weeks or months to treat SIBO, and when we prescribe a non-absorbed, very safe kind of antibiotic treatment to take care of SIBO, we know it's going to work quickly, and it leads to very fast resolution of symptoms. It's better than putting patients on a low FODMAP diet for weeks or months on end. So, yeah.
Other implications. Well, I think I covered everybody. I hope I did.
Great.
You covered so much information for us, and your time. You were so generous with your time. I can't thank you enough.
Oh, happy to help.
Thank you to everybody who joined us. I don't know if George is still with us, but I'm going to wrap it up and say, just again, thank you so much for all the work you do, for Dr. Zeltzer, and for the CHYP team that help us all put the mind-body connection together and help get kids better. So thank you, everybody, for joining us today.
And thank you, Georgia. Thank you, Dana.
Thank you, everybody. Thank you. Hope to see you for the other 2 parts of the series. The next one, as Dana said, is on Friday at 10 a.m. Please feel free to contact us with any questions. You can look at our website, mychip.org, and follow us on social media. We have a Facebook, Twitter, Instagram, and YouTube channel, and we will be sending out the recording of this discussion to you all over email. So thank you again so much, Dr. Ziring and Dana, for taking the time to speak with us today, and thank you, everybody, for your questions. Have a great day.
Thank you, everybody.
Right. Bye-bye.
Bye.